a single-payer system for 10 years and hope to eventually get back into one. I'd like to welcome you all here on behalf of the University and the School of Public Health. And we're here, I study health transformation and learning, and today we're going to learn a little about potential health transformation that we're all hoping for. It's good to see all of you showing up. We have people from Costa Rica who have a single-payer system, if I'm not mistaken. And we're here together to hear Dr. Himmelstein speak. And before that, I'd like to welcome David Gray, who's the chairperson of the Capital District chapter of the PNHP. Make yourselves at home. There's some refreshments there, and I hope you enjoyed the talk.
Thank you. I'm glad to see you're all here. My name is David Gray, actually. I'm getting gray, though. I've noticed that. And I'm the current chairperson of the Capital District chapter of the Physicians for National Health program. And I want to just say a very few words because I know you're really not here to hear me. In 1966, Martin Luther King, this is a quote that many people have probably heard, said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I think that that's a sentiment that basically informed the founding of PNHP, and we're fortunate tonight to have one of those founders here as our speaker, Dr. David Himmelstein. The Capital District region has had a chapter for over a decade, and it's a very always active chapter with a changing cast of characters. And I would invite people to, if you're interested, to look at the literature that we've got in the back, and to consider signing up at least to be on our email list so that we can keep you informed of single-payer events in the Capital District as they're happening. I'd like to thank the organizations that have helped us to publicize and sponsor this, including, of course, the School of Public Health. Thank you, Dr. Podrowski. And Capital District Alliance for Universal Healthcare, which is a group of healthcare professionals, labor professionals, and people from different organizations who have been meeting together for, how long, Richard? More than 10 years?
2005.
Okay, for 10 years. Whose leading light is Dr. Richard Propp, who will be here afterwards selling at cost copies of a movie called The Healthcare Movie, which is about the Canadian healthcare system, and where he is very interested in having people get these so that they can show them in local libraries and in their own homes and wherever else they want to. I'd also like to thank Single Payer New York, and we have Representative Alice Brody, who's here from that, and she will also be signing people up hopefully for a lobby day, which is on May 5th coming up at the state capitol. The League of Women Voters of Rensselaer County, the Students for National Health program, and the Healthcare Value Forums, all of which are organizations which discuss healthcare reform in the Capital District. And also the Albany Times Union and WAMC, which have helped us to publicize this event. I hope that Dr. Himmelstein's talk will energize you, and as I said, the opportunities to participate and to join in the things that people are doing in the Capital District are all out there on those tables, and all we need is your name and information on how to reach you, and we'll be happy to engage you. And now I'd like to ask a representative of the Students for National Health program, Justin Figueros, to introduce our speaker.
Hello, my name is Justin Figueros, like Dr. Gray said, and I'm a second-year medical student at Albany Medical College and a member of Students for a National Health Plan. It's my great pleasure tonight to be able to introduce our speaker, Dr. David Himmelstein. Dr. Himmelstein is a nationally recognized physician, healthcare researcher, and authority on single-payer health systems. He received his medical degree from Columbia University and completed his training at Highland Hospital and University of California, San Francisco, and completed the rest of his fellowship in general internal medicine at Harvard. He is now a professor in the CUNY, or City University of New York, School of Public Health at Hunter College, adjunct clinical professor at Albert Einstein College of Medicine, and a lecturer at Harvard Medical School. He has served as chief of the Division of Social and Community Medicine at Cambridge Hospital. Dr. Himmelstein has also authored or co-authored more than 100 journal articles and 3 books, including widely cited studies of medical bankruptcy and the high administrative costs of the U.S. healthcare system. His research has led to the enactment of EMTALA, or the Emergency Medical Treatment and Labor Act, the law that banned the practice of patient dumping in hospitals. In addition, as a co-founder of Physicians for a National Health Program, Dr. Himmelstein co-edits PNHP's newsletter and is a principal author of PNHP articles published in JAMA and the New England Journal of Medicine. And he publishes these works in conjunction with Dr. Steffi Wohlhandler, who I feel also deserves a shout out, though she couldn't be here today. And without further ado, I'm going to stop talking and let tonight's speaker come up and grace you all with his presence.
Thanks very much. I always worry about introductions. Years ago, Eleanor Roosevelt was speaking up in Maine, and a woman said, "How do you want to be introduced?" And she said, "Make it brief." And the woman said, "This is Eleanor Roosevelt, and the less said about her, the better." Nice introduction. I'm just getting used to New York City, having moved there after 30 years in Cambridge, Mass. And it took some adjustment to get used to the waiters saying to you, "Is anything all right?" So I'm going to say mostly conventional things about our healthcare system tonight, and a few things that are unconventional. The conventional things are that we're still in quite deep trouble, that we have enormous problems that have not been solved in our healthcare system. And the unconventional part is that something relatively simple and straightforward could be done to fix it. And I'm going to end actually with some brief discussion of what's happened in Vermont over the last couple of months, because we're fairly local here, and I feel a little bit local in Vermont, having gone to college there actually as an undergraduate. So this is where I came in on the healthcare debates. As an intern, I cared for this patient, a 59-year-old man, that's his chart behind the red letters there, who suffered an open skull fracture in a car accident and was taken to a hospital owned by an HMO in the San Francisco Bay Area. And he had what we refer to as a negative wallet biopsy. So no insurance card was found. And as a result, the HMO put him in an ambulance and transferred him to our public hospital, where when he arrived, he literally had brain and bone showing through his wound. He also had a C1 fracture, a fractured neck, which had not been discovered at the initial hospital that had cared for him. He was quite miraculously not quadriplegic, as one might well be from a broken neck. Underwent neurosurgical stabilization, and it turned out he was actually a patient of the HMO that had initially refused to care for him. They couldn't find him in their computer system for some reason. And once they found that out, they immediately demanded his transfer back to the hospital that had refused to care for him at the outset. And the reason I start with this case is that he's an illustration of two aspects of our healthcare system. One is he was abused on the first occasion because he was thought to be uninsured. And on the second occasion, he was abused because he had insurance. And in some ways, that's emblematic of our healthcare system, that patients are abused both with and without insurance. Now, we had and still have an enormous number of people uninsured in our country. Before the passage of Obamacare, about 47 million uninsured. The red line there is what's expected to happen. This is Congressional Budget Office estimates, what they expect to happen to the number of uninsured under Obamacare. The yellow is what would have happened if the Supreme Court hadn't said that states can opt out of expanding Medicaid. And the point here is, even if Obamacare had been carried out exactly as planned, we would still have had about 25 million uninsured in this country. We will have about 30 million uninsured as things turned out. And some work that one of my fellows with our group published a number of years ago, for every million people who are uninsured in our country, about 1,000 people die each year. And here are just some estimates for some of our larger states, but nationwide, about 45,000 people will die this year because of lack of health insurance. It's our 6th leading cause of death, and we continue it year after year after year. We've had, over my professional lifetime, an almost steady erosion of our private insurance system. The downward trend of the blue here only interrupted with a slight upward shift in the yellow, which is the projections with Obamacare. We don't have firm figures yet, but again, this is what the Congressional Budget Office expects will happen. So back in 1978, about 84% of Americans had private insurance. We're down to mid-60s at this point. And the only reason we haven't had a much worse disaster in our healthcare system is the public sector has been expanding to fill the gap. This is the number of people covered by Medicaid, and again, the change in color is projections of what is expected under Obamacare. We don't have firm figures to count on yet. And one of the problems is with Medicaid, we have not really fully adequate coverage. This is what's called a secret shopper study. Researchers called practitioners in Chicago and tried to make appointments saying they had a child who had been cared for in an emergency room, and they were told the child needed to see a specialist and follow up within 1 week. So for calling an orthopedist, the child was said to have had a broken arm that needed orthopedic surgical attention within 1 week. And if you had private insurance, 98% of orthopedists would make an appointment for you within 1 week. If you had Medicaid, 20% of orthopedic offices would make such an appointment, and that was true of all of the specialties. And in fact, Medicaid doesn't get you full access to care in this country. And even for those with private insurance, they're suffering more and more difficulties. So this is the percent of workers whose employers are providing them coverage who have a deductible in their health insurance of at least $1,000. So back in 2006, only 10% of covered workers had that large a deductible. As of the most recent year, 41% have a deductible at least that high. And I'll get back to this major problem in our healthcare system a little bit later on. And we know that less than adequate coverage is potentially an enormous problem. Here's a study that looked at people with heart attacks and whether they delayed going to the hospital after they'd had their chest pain. And the insured, or the bar on your left there, the uninsured, or the bar on your right, they were 38% more likely to delay seeking care in an emergency, in this case chest pain. The underinsured, people who worried about the size of their medical bills despite having insurance, were 21% more likely to delay seeking care for a heart attack, and that's potentially a mortal delay. Time is muscle, is what the cardiologists tell us. The longer you delay, the more heart muscle you lose, and that can be fatal. Well, we know that for children with asthma, higher medication copayments, on the left, fewer days using the medications that prevent an asthma attack, and on the right there, more likely to be admitted to the hospital. So for kids with copayments for their medications, that means if you've got asthma, more likely to end up in the hospital. And health costs for the privately insured, this is a recent survey. Just on your left, people with high deductible plans, 24% of them said that they had used all or most of their savings within the last year because of a medical bill. I won't go through all of the other problems detailed on this slide. But the point here is insured people having a major problem affording the medical care they need. And some work that we did with a colleague then at Harvard Law School, where we interviewed people in bankruptcy courts around the country. This was before Elizabeth Warren became a well-known figure. What we found was that bankruptcy is common, and Elizabeth knew that, I didn't. Turns out more American women file for bankruptcy each year than graduate from college. And what we found is that 62% of those bankruptcies had a major contributor from my profession. Either medical bills or illness was a major cause of their bankruptcy. It may not have been the only cause. A common story was someone got sick, they got too sick to work, they lost their job and their income just as the medical bills came in. So it was both loss of job and loss of and medical bills that drove them to bankruptcy. But this slide shows one of the other findings, and that is, of all of the medically bankrupt, 60% had private insurance. Even private insurance didn't protect them. Well, this is part of a broader problem in our society, the polarization of income and wealth, and I'll just briefly digress on that here. In my youth, all elements of our society saw rising tides. So as you're going from left to right on this slide, you're going from poorer to richer. And the point here is that between 1950 and 1978, all of the income groups in our society were seeing rises in their income. Now here's the more recent pattern. And what you see is the bottom 20% in the most recent period actually got poorer. And of course the top 5% got much richer. And if you segmented that off to the top 1%, the bar would be off this scale by a considerable amount. We've had rising income polarization. In fact, now our income inequality in this country is the worst of any developed nation. So I didn't include the slide in this from 1982. The U.S. was run-of-the-mill in 1982. We're now among the most unequal of the societies, and among wealthy nations, the most unequal. And mirroring that is the enormous numbers of people whom we put in jail. So we're used to thinking of Russia or Iran as being repressive societies, but we put far more people in jail as a proportion of our population than any other society on the face of the earth. And more directly relevant maybe to a healthcare talk, we've seen widening health inequalities. This is data from the Social Security Administration, and they divided the population into the richest half of the population and the poorer half of the population. The blue is the richer half and the yellow is the poorer half. And here they're showing the remaining life expectancy after you turn 60. And back in 1972, there was a 1.2-year difference between the richer and poorer halves of our population. And by 2001, the most recent data that Social Security has published, there's a 6-year difference. So the income inequalities are very much mirrored in starkly rising health inequalities in our society. In effect, our healthcare system rations medical care. About a third of Americans are completely uninsured or so grossly underinsured that major illness is a clear financial catastrophe. They're often denied care or can't get it when they're sick, and they're sicker and they die younger because of it. And when I first got to Harvard and made this slide, actually, my then chair of my department said, "You're misusing the word rationing." The dictionary defines rationing as an egalitarian distribution of a scarce resource. And we don't distribute the resources of our medical care system in anything like an egalitarian manner, and they're not scarce. So here's data from the RAND Corporation. They tell us that about 16% of hysterectomies are clearly unnecessary, 25% of questionable value. And for each of these procedures that's been looked at, and the more recent data, if anything, is more striking than this. Very large proportions of the procedures and expensive stuff we do not only does patients no good, but may actually harm them. So, in effect, I then made this slide. We ration a surplus of medical resources. In many parts of the country, we have empty hospital beds. We do millions of unnecessary operations. We have excess high-tech facilities. In Boston, at one point, we had 5 hospitals doing heart transplants. None of them were doing enough of them to be any good at it. That lowered the quality of care, and it enormously increased the cost of care. And at the same time that we have that surplus of resources, we're denying needed care to millions of our fellow citizens and colleagues. Well, it takes a lot of work to keep sick patients away from empty hospital beds and idle physicians and nurses. The yellow here is the number of doctors in our society, and the blue is the number of administrative personnel. Just by way of disclosure, I've actually inflated the yellow part of this slide, because if I drew it to scale, you wouldn't be able to see it. Well, one of the things that we've spent a lot of administrative energy on is what one of my Canadian colleagues says, trying to find out what doctors and patients are doing together and getting them to stop it. And earlier, that movement was called managed care, or HMOs, but that kind of got a bad name, so we've renamed them ACOs, or Accountable Care Organizations. And those of you old enough to remember Yogi Berra will remember his famous saying, "It's like deja vu all over again." Well, HMOs, those of us old enough to remember the 80s and 90s, will know why patients are worried about them. So here's a survey that the Kaiser Foundation did with colleagues at Harvard, asking patients, here are 2 different ways Medicare could pay doctors. Which of these do you think would be better for you, fee-for-service or capitation? And patients voted very heavily for fee-for-service, despite the welter of publicity that fee-for-service is the problem in our healthcare system. Now, yet our health policy is saying we need to move towards paying doctors to do less. Now, I'm not in favor of paying doctors to do more, but I'm equally not in favor of paying doctors to do less. Yeah, how do I, there we go. Why is that? Well, we have a lot of data that that's a problem. Back in the 1970s and 80s, the Rand Corporation spent $120 million of taxpayers' money to do the only experiment in health insurance that was ever done in a randomized, controlled way. They randomized patients to different insurance products, including what was then probably the best HMO in the country, Group Health Cooperative of Puget Sound out in Seattle. And what they found is that poorer and sicker patients didn't do well in HMOs, get the attention of their doctors. Now, my personal favorite from that era was U.S. healthcare, because I was a participating physician in U.S. healthcare. U.S. healthcare, by the way, is now called Aetna, so you may recognize them. U.S. healthcare, in my contract, I got big bonuses for every hospital day that I denied my patients. So if my patient was in the hospital, part of it came out of my income as a primary care doctor. Every specialist referral I made came out of my income as a primary care doctor, ER visits and so on. When I did out the math in my contract back then, if I'd had 1,500 patients in this HMO, I could have made bonuses of about $130,000 by denying care. If I had not made any of those bonuses, I would have roughly made my office overhead and gotten nothing for income. There was this clause in my contract with them, and it said, physicians shall agree not to take any action or make any communication which undermines or could undermine the confidence of enrollees, potential enrollees, their employers, unions, or the public in U.S. healthcare or the quality of U.S. healthcare coverage. Each physician must be supportive of the philosophy and concept of U.S. healthcare, whatever that is. And physician shall keep the proprietary information which was defined elsewhere as payment rates, those bonuses, utilization review procedures, and this agreement strictly confidential. And it turned out I wasn't supposed to publish this clause in the New England Journal of Medicine. Actually, I had crossed out this clause in my contract, but I got this note from them after I published it that said, pursuant to your agreement, and in particular section 5.2, U.S. healthcare is terminating your agreement. Now, section 5.2 was actually a clause that said they could terminate any doctor at any time for any reason or for no reason. And most doctors were smart enough to know that you don't criticize them in public if you don't want to be terminated. I wasn't the only one in trouble, by the way. Gordon Sack was primary care doctor of the month in the Houston area in Aetna's U.S. healthcare plan in July, and they terminated him in September. And the why is kind of interesting there. When you get a reputation as a particularly good doctor, sick patients seek you out. And insurance plans really don't want sick patients. And one way to get rid of them is to get rid of their doctors. And that's why Gordon Sack was fired. I can't claim that on. Well, there are some people who've done very well in HMOs. My personal favorite is no longer on this list, Jack Rowe, who was the CEO of Aetna. Before that, he was the chief of geriatrics at Harvard, was a fine colleague there. But we couldn't pay Jack the $225,000 per day that he made during his 6 years as the CEO at Aetna. But Mark Bertolini, his successor, has done well as well. He made $30 million in 2013. The figures, by the way, are just trickling out about the 2014 compensation, and I'm happy to tell you that they're up. These folks are doing better. I have nothing against those people. The problem is their income is coming out of my patients' pockets. So for every dollar that we pay into Aetna, only 83 cents worth of care comes out. And Aetna isn't alone. All of the other big health insurance companies are in the same ballpark. In fact, they're a little worse. So we can't afford these people. That's our basic problem, is the middlemen are taking enormous amounts of money. And just to put this in perspective, Medicare takes 2%. 2%. Aetna takes 17%. That's an enormous difference. Now, we had hoped that the Affordable Care Act would cut this amount, but it hasn't. Some data that we recently published looking before and after the regulations on insurance overhead went into effect, and it turns out they figured out ways to squirm around all those regulations. What we used to call utilization review is now labeled as patient management, and that's a clinical cost. But it's the same amount of overhead that our insurance companies are taking. And as we've seen the move to ACOs and to large corporate takeover of medical practice, it actually raises costs. So here's some data that the larger the physician practice group, the more they're able to charge. Basically, they use their clout to extract higher prices. And one of the features of the HMO and ACO movement has been to say you can't exist as a small practice anymore. To stay in business, you have to either be owned by a hospital or a large insurer, and therefore have the bargaining clout to compete in this market. And that works. It gets you about a 40% increase in your fees. And by the way, the quality data is, if anything, suggestive that small practice is producing better quality care than the large consolidated practice. This is the avoidable hospital admissions, and small practices have fewer admissions. Physician-owned practices have fewer admissions than hospital-owned practices. Yet we're moving away from the traditional non-corporate practice of medicine to more and more corporate practice. In the Medicare system, we've seen a move towards managed care within Medicare. So in the Medicare system, starting in 1983, we passed a law that said if you want to, Medicare will pay your premium if you join an HMO. And despite the fact that Medicare has 2% overhead and the HMOs have 15% overhead in Medicare, it's a little lower than the 17–18% of HMOs overall, but 15% versus 2%. Here's what's happened. More and more seniors are joining HMOs. Now, how can HMOs compete with traditional Medicare despite having overhead that's 7 times as high? Well, the way you compete is that you draw healthy patients and you avoid sick patients. Now, Medicare pays you $12,000 for each patient you sign up. 19% of Medicare patients cost Medicare $0 in the course of a year. If you sign up that 19%, you get $12,000 for each of them. They have cost you nothing. Now, is that just my fantasy? No, it's not. I mean, they've realized the basic law of medicine here, or of insurance medicine at least. As you go from left to right, you're going from healthy to sick. And the point here is the sickest 10% of patients in that right-hand bar account for 62% of total healthcare costs. If you avoid them, you're doing well. Well, here's a study from Florida back in the 1990s. Fee-for-service Medicare patients are listed as the yellow bar there. That's the average cost of a Medicare patient. We've set it at 100 arbitrarily. Patients who then joined the HMOs, on average, cost Medicare only 2/3 as much before they joined the HMO. We don't know what it cost the HMO. They're not required to report that. But what we do know is if you didn't cost much last year, you're not likely to cost very much this year. So healthy people were joining the HMOs. And people who got out of the HMOs in traditional Medicare, the right-hand bar there, they cost Medicare 80% more than the average Medicare patient. So what was happening was people were getting out to get their hip replacements, or to get their knee replacements, or their elective prostate cancers, prostate surgery. Now, that's not to blame the patient. In fact, as a primary care doctor, I might advise them to do that. I might tell them, if you're in the HMO, there's only one hospital your HMO will pay for your care at, and that's not the place I would go to have my hip replaced. But if you're in traditional Medicare, you can go anywhere. So it's to your advantage to get out, and in fact, that's what was happening, is sick people were leaving the HMOs, and they then tried to adjust for the severity of illness of the patients in HMOs. It turned out the HMOs were able to beat that as well. And they were able to beat it because within each category of illness, there are expensive patients and there are inexpensive patients. I have one example here. Congestive heart failure increases your capitation rate by 41% as an HMO. That diagnosis. Now, by the time you get to be 80 years old, almost everybody, if you do a test called an echocardiogram, can be diagnosed with something that can be labeled congestive heart failure. But most of those patients will have no symptoms and need no medical care and cost you nothing. And HMOs are now encouraging some doctors to do screening echocardiograms to raise their capitation payments, basically cheating Medicare out of funds. And we've done some work on this. Overpayments since 1985 to HMOs have totaled $275 billion. That's what they've gotten out of Medicare. Now, we also know, because of not because of my research, but because of a colleague's research, that 95% of these plans cheat on their quality scores. Most quality measures we can't check. There's one that Medicare collects that one can check. That's the percent of patients who are prescribed a medicine that ought never to be prescribed to an elderly patient. So this researcher actually managed to track down that data, and 95% of the plans had falsely reported their score. That's the quality monitoring we have, the quality of the quality monitoring. And you can get around quality monitoring in other ways as well. Here's an example from a hospital I know well. Its adjusted Medicare mortality rate was 42% above predicted. That's an emergency. We were killing patients. And the administration did what most administrations today would do in that circumstance. They hired a consultant. They spent $500,000 on the consultant, and what the consultant did was they lowered our adjusted mortality to 1% above expected within 3 months and to 14% below expected in 6 months. That's a spectacular achievement. Now, how did they do it? It turns out that that mortality rate, you have to adjust for how sick the patients are. And how sick the patients are depends on what's written down in their charts or what's logged into the computer. And what the consultants did was they put a nurse on each of the wards who went to each of the interns, and every time they'd written something in the chart that wouldn't count to make the patient look sicker, they told them to rewrite it in a way that would make the patient look sicker. So instead of acute kidney insufficiency, they told them to write acute renal failure. Instead of magnesium 1.6, they told them to write hypomagnesemia, and so on. These are all synonyms and have no clinical meaning, but they had a huge meaning for the risk adjustment score, and they got the hospital $2 million in extra payment from Medicare because our patients looked sicker. So these are the kind of games we're playing as a routine in our healthcare system. Here's another example. This is an actual newsletter that a consultant sends out. Here, if you diagnose a patient with pneumonia and congestive heart failure, CHF, that's example number 1 up there. The hospital gets $3,870.35. And example 4 at the bottom, if you instead write down aspiration pneumonia and acute on chronic systolic heart failure. And for those of you who are not doctors in the audience, number 4 is a synonym for what number 1 is. But you get $11,000 for that instead of $3,000. Those are the games we're now playing. And HMOs and accountable care organizations are now doing a new trick. They're hiring house call doctors not to go treat the patient, but to add diagnoses. They go visit patients who haven't seen a doctor this year, and therefore they're not getting the full Medicare payment because they don't have any diagnoses. And they examine them not to improve the patient's outcomes, but to label them with diagnoses you can bill for. The newest scam, by the way, is end-of-life navigators. So plans and ACOs are hiring a firm to do cold calling to very sick patients to get them to say, I don't want to be resuscitated, because that's cheaper for your plan. Well, Milton Friedman, the guru of free market economics, told us years ago what to expect in this kind of system. He said, few trends could so thoroughly undermine the foundations of our free society as the acceptance by corporate officials of a social responsibility other than to make as much money for their shareholders as possible. And the problem is not that people are misbehaving. It's that they're behaving exactly as they're supposed to once we have a corporate structure running our healthcare system. We looked years ago at all of the quality measures that HMOs reported. For every quality measure, the for-profit HMOs did worse than the nonprofit. We tried to repeat this more recently, and the data was no longer available because after we published this, the for-profit plans refused to allow release of their data to researchers. Well, we looked at who owns tobacco stock. The largest owners of tobacco stock in the country are insurance companies. We call this the combined taxidermy and veterinarian approach. Either way, you get your dog back. It's just a dramatic illustration that these folks are not They're not evil people, but they're doing what they have to do. If they don't do this, they get fired, and someone who's willing to make as much money for their shareholders as possible comes in. This is a complex slide. I'm not going to go through all the detail here. It represents a summary of every study ever published comparing the death rates at for-profit and not-for-profit dialysis clinics. The point here is 9% more deaths adjusting for how sick the patients are at for-profit than non-profit dialysis. We kill 1,500 people a year by allowing for-profit companies to run 70% of our dialysis clinics. Two firms dominate this field. One of them makes dialysis membranes. They label them single-use only, but in their own clinics they reuse them because that makes them more money. And it also kills people. Same thing in hospitals. For-profit hospitals, 20% of the hospital market, 2% higher death rates. Well, it's not that they're more efficient, same thing, all the studies ever published. 19% higher costs. They're not good at anything except extracting money. They're not more efficient. But that's who's coming to dominate our healthcare system, is the folks who are in it for the money. Even our hospices are now being turned over to for-profit corporations. 57% of hospices owned by for-profit organizations, and a raft of data that they're treating patients really for the money or mistreating patients. Now, I want to turn for a minute to what's going on in our country as compared to other countries. I've shown here the health care spending per person. In the US at the bottom, the yellow is public money, and the orange or brown is private money. And the point here is that in government funds, we spend more on our healthcare system than any other nation spends on its entire healthcare system, public plus private. We, in effect, are already paying for national health insurance, but we don't get it in this country. And our life expectancy in U.S. is going to be in yellow, which is a little dim on these slides. I'll go through them quickly in the interest of time. Our life expectancy is lower than other countries we would compare ourselves to. The infant mortality rate is distressingly high. We can't claim that our poor health outcomes are because of bad habits. We smoke less than people in most other countries. We, by the way, don't have high costs because we spend so much time in the hospital. Americans have less hospital care than people in most other wealthy nations. We don't see the doctor very often. Americans are not avid consumers of medical care by international standards. We don't even get more of some kinds of high-tech care. Here's bone marrow transplants, where we're kind of middle of the pack. Paul Tsongas, when he was running for president years ago before his death from leukemia, said he wouldn't support a Canadian-style single-payer system because he thought under it he wouldn't have the possibility of a bone marrow transplant, which was a surprise to the doctors in Toronto who invented that procedure and who did it in larger numbers per capita than we were doing it in Boston. But the image is that people in other countries don't get care. It is true we get some kinds of care less often than in many other countries, like home dialysis, which is what patients prefer, because that's not profitable for the 70% of our dialysis facilities that are for-profit. What we get enormous amounts of is insurance overhead. So for every man, woman, and child in the country, we get about $600 a year in insurance overhead. And other countries are paying far less. Canada, $148 per person per year. So $450 for every man, woman, and child in excess insurance overhead. Canada's program is a simple program. Federal government says province can get matching funds from the federal government. They later turned it into block grants if it had a program that met 4 criteria. Universal coverage, which means 98% of the people in the province have to have actually picked up an insurance card. that does not impede either by charges or otherwise reasonable access to care. What that means is no co-payments, no deductibles for covered services. Everybody in Canada has better coverage than anyone in this room. Second is portability of benefits. If you're from Ontario and get sick in Quebec, you have to be covered. And third is coverage for all medically necessary services, which the feds have never defined. The program was really passed when that meant doctor and hospital. And they're not as comprehensive on long-term care and outpatient drugs. There's a big fight in Canada about expanding coverage to those things. And fourth is publicly administered through a nonprofit program, because when they pioneered the program in Saskatchewan, they found that it cost 3 times as much to subcontract to a private insurer as to do it in the public sector. So they said, we can't afford that. The percent of people seeing a doctor who had serious symptoms, things like chest pain or coughing up blood, rose dramatically within 1 year of the passage of the program in Quebec. People got the care they needed. Not everybody, but a much larger proportion of people. Infant mortality rate was higher than ours. They passed that program. It went lower than ours, and it stayed there. Health costs, which used to be same as ours, flattened out in Canada. It's turned out to be the most effective cost containment that one could imagine. In fact, if anything, maybe too effective. But if our problem is high cost, this is the solution. Well, as I said, insurance overhead is part of the difference, but it's not just insurance overhead. We went and visited a friend hospitalized at Toronto General Hospital, since changed its name. It's a 900-bed tertiary care academic medical center, full range of services. Our friend was an American, and he asked us to look into his bill. The billing office at Toronto General Hospital was 3 people, whose job was to send bills to Americans who wandered across the border. Because they got paid like a fire department gets paid in this country. They get 1 check a month for their entire operation. Everybody has the same coverage. No need to fix by Massachusetts General Hospital, same size, same range of services. 352 full-time equivalent people in the billing office. Not because Mass General is inefficient, but because that's what you have to do as a hospital to collect your bills. Canadian hospitals have an enormous saving on that, and Canadian doctors do too. We have recently published data from 8 countries, and the U.S. is the outlier in how much we spend, and this is per person per year on hospital administration. As I said, doctors, Canadian doctor, there's 1 insurer, there's 1 form. You check one of the 10 boxes on the form. Now they do it by computer, and you throw all of your bills into 1 envelope or send it once a month. That's the billing operation. The average American doctor employs 1 full-time person to do nothing but their billing. Well, the difference is enormous. We're spending $2,200 per person in the country on excess bureaucracy that Canadians don't have. That's enough to cover all of the uninsured, to upgrade coverage for all the rest of us, to give everybody full coverage for long-term care, if only we made a rational healthcare system. Canadian doctors are not starving. You know, that's not how they're economizing. Family docs are getting by under $270,000 a year. The ophthalmologists are scraping by on $580,000 a year. Canadian docs aren't fleeing to the U.S. In fact, if anything, more are going north than are coming south. How has Canada controlled costs? Slide's gone off the bottom for some reason. Lower administrative costs, lump sum global budgets for hospitals, which does 2 things. That simplifies billing. It also allows them to say, we're going to pay you for the care of patients, but you can't keep any of that money you don't spend on your patients in order to build the next big new building or buy a fancy machine. We're going to decide where those new buildings need to be built. And we're not going to have 5 heart transplant programs in this city. We're only going to have 1 because that's the best way to do it. Single buyer purchasing power has also been important. They get lower drug prices. They buy them from our drug companies. but they get better prices. Well, in contrast, our health reform, the Lancet, the leading British journal, their cover said the health reform process exposes how corporate influence renders the U.S. government incapable of making policy on the basis of evidence and the public interest. And unfortunately, that's pretty much what we've got. We have a mandate model for reform. Instead of saying national health insurance, everybody in one insurance pool, simple to administer, pay hospitals like a fire department, we went with a mandate model. And you may ask, why do I have Richard Nixon's picture on this? It's because Richard Nixon was actually the first president to propose this health reform. And it's expanded Medicaid-like program for the poor, subsidies for low income, employer mandate, individual mandate, and insurance exchanges. Now, I'm not going to ask you to believe just me that this was Richard Nixon's and then Mitt Romney's program. If the audiovisual
President Nixon today pledged his administration to a new national health plan that would benefit not only patients, but also doctors and citizens who enjoy good health. But beating him to the punch, Senator Edward Kennedy earlier proposed an alternate plan that goes much further than the administration.
I am proposing today a new national health strategy. It helps more people pay for care, but it also expands the supply of health services and makes them more efficient. It emphasizes keeping people well, not just making people well.
The President's program, as announced today as a National Health Partnership program, I believe is really a partnership program that will provide billions of dollars to the health insurance companies. It's really a partnership between the administration and the insurance companies. It's not a partnership between the patients and the doctors in this nation.
The administration proposal will provide different plans for 4 categories of Americans. For 150 million working people and their families, employers would be required to buy health insurance providing a basic package of benefits, eventually they paying 3/4 of the premiums. For some 20 million of the working poor and their families, the current free Medicaid services would be replaced by private health insurance fully paid by the government for the poorest, with a sliding scale of contributions for families earning more than $3,000. For the 21 million aging Americans, the $5.60 monthly Medicare premium for optional doctor services would be dropped, Social Security taxes adjusted to make up the cost. For some 30 million domestic, self-employed and others, lower cost by being enabled to buy policies at group rates from insurance pools.
Well, so our plan is not a very new one. It is a very complex one, so I've drawn schematically so that you can understand it, an explanation of it. Notice we've crossed out single payer, how you get from needing care to getting it. I just want to make clear that I'm not an advocate of the Republican alternative, which is get sick and die penniless. And here was the reaction to the startup of the health exchanges. But it's not that they flubbed something that was easy, it's that it was actually very difficult. And the difficulty was that you had to interface with an enormous number of different information sources to make sure that the person was eligible for exactly what they were supposed to be eligible for. And that meant checking with the IRS, the Treasury Department, the Social Security Administration, Homeland Security, Health and Human Services. All of these was actually complex. I want to contrast that with Medicare software. This is the Medicare sign-up card of the first enrollee in Medicare, Harry S. Truman. And Medicare signed up 18.9 million seniors within 11 months of its passage. 99% of eligible seniors were signed up within 11 months of the legislation being passed. It also desegregated virtually every hospital ward in the country. In a day when we had no computers and this was all done by hand. We know that the Obamacare has been partly under assault because of states refusing to expand Medicaid, part of the plan, and one of my students actually calculated some of the toll of this. estimated between 7,000 and 17,000 deaths will result from states' decisions not to expand Medicaid. So again, I'm by no means an advocate of the Republican position against Obamacare. But one of the things that's happened as a result of this opposition to the expansion of Medicaid is the federal government agreeing to allow states to do terrible things to their Medicaid program. So Iowa is now charging $5 a month premiums for adults with incomes above 50% of poverty. What that means is if you make $5,000 a year, you have to pay $5 a month toward your premium or you have no insurance. Medicaid previously had to be free to these people. Michigan, 2% of income. Indiana, $3 to $15 a month contribution. We're seeing the gutting of Medicaid programs. We know that this will drive hundreds of thousands of people away from the care that they need because they can't afford it. And the program, as it's now been implemented, gives you coverage which is inadequate coverage. In New York State, a typical bronze plan for a family carries a $6,000 deductible with 50% co-insurance after that deductible is met, up to an out-of-pocket maximum of $12,700. Now imagine that you have essentially no coverage until you've paid $6,000 and very little coverage until $12,700. Now, that's not just New York State. This is just a slide to show you that's typical around the country. That's about what we're seeing everywhere. Here's Federal Reserve survey of how much savings people have. The bottom 40%, the two left bars there, which you can't even see because they're so small, the average savings is less than $4,100. What that means is 40% of the population would be bankrupted by the time they hit their deductible. Another 20% or so would be bankrupted when they hit the out-of-pocket maximum. And that's the kind of insurance we have. We're also told we should shop wisely. This survey asked people to answer a series of questions about the lingo of cost sharing. So they put up on the web the details of your insurance plan. Of people who are college graduates, 51% could correctly answer the questions of what does that language mean. Some high school is 25%. We're asking people to shop where they can't possibly understand what they're shopping for. And we're pushing people into plans where they can only get to see a very narrow slice of the health professionals in their community, so-called narrow network plans. And contrast that with Canada, where as a Canadian, one could go to any doctor, any hospital in the country. And under national health insurance, that's what we were saying should be the case. You want to see a doctor, go see that doctor. You want to go to a particular hospital, go to that hospital. Some calculations we haven't published yet. Over the next 10 years, the ACA will increase insurance overhead by $266 billion. These are figures taken from the federal government's own estimates. That's the amount of money. That's why the insurance companies are booming. I'm going to skip over that one. I want to turn now to state initiatives, and this will be the last piece of my talk. State initiatives for single payer are particularly attractive in this era where Congress seems so hopeless. There's a lower bar to state than national legislation. Media outlets are often more willing to cover state initiatives that seem more hopeful than national legislation. And state legislators can influence the Congress themselves, become Congress people. You can tailor state programs to local problems, and maybe you can avoid some of the baggage of Washington lobbying and rulemaking. And people point to Saskatchewan, which was the first province of Canada that got a provincial health insurance plan, and maybe that's the way we should do it here. Now, my wife is fond of reminding me that state can't mean that we do it state by state, because she grew up in Louisiana. And if we depend on state by state, her home will never have a decent health insurance program. But state as a bridge to national has some attractiveness. It's also got obstacles that we need to recognize. You need federal waivers to actually do it. So the key to administrative simplicity is you've got to have everybody in one pot. Otherwise, you can't pay a hospital like a fire department. You've got to bill because you've got to figure out which insurer is responsible for which payment. So you've got to get waivers for the federal programs like Medicare, Medicaid, TRICARE, which is the military program, Federal Employee Health Benefit Program. If you leave those federal programs out, you sacrifice much of the administrative savings that are really key to doing this. Waivers have risks, and we've already begun to see the problem with this. So while Vermont started asking for waivers, it's also true that several other states have asked for waivers to do very backward program. You saw some of what they've done with Medicaid waivers, is to start charging poor people for Medicaid. And we worry that if you can get a waiver to do something good with Medicare, you could get a waiver to do something bad with Medicare. Border crossing can complicate things. In some states, that's not a big issue. In other states, it is. Corporate political power is portable, so it's easy to send money across borders if you're threatened there. And we'll see that in Vermont in a little bit. As a state program, you have a problem with a law called ERISA, which is a federal law that says that if an employer self-insures, which most large employers do, that the state can't make rules about that insurance. And as the federal government, you could do away with that, but as a state government, you can't. And finally, I'm concerned that if you label a compromised state program single payer, you risk sullying the image of single payer. And in some respects, I think that's what happened in Vermont. Now, in Vermont, some background. First, there's been exemplary grassroots organizing and very strong labor support that really puts single payer on the agenda. There are folks who have worked there for a decade or more and done very effective work. In 2010, Peter Shumlin ran for governor, and in Vermont, there's a very strong third party. In fact, the senator from Vermont, Bernard Sanders, is a member of that third party. And as part of the condition for that third party, the Progressive Party, not running a candidate against Shumlin, they said, if you will support single payer and one or two other things, we won't run an opposition candidate. He said, okay, he supported single payer. Won narrowly, beat the Republican. But he had no clear plan for what that meant at that point. That becomes important in later time. After he was elected, he and the legislature commissioned a colleague at Harvard, Bill Shao, to study health reform options, including single payer. And Shao issued a long report in which he rejected single payer as not politically feasible, but proposed a hybrid model, a public-private hybrid, he called it. He said you could save $580 million, which in Vermont is big money, in the first year on administration and by driving down drug prices. So that's the background. In 2011, based on the Shao report, they passed a law, but the law didn't say what the details of the program should be. The law said, Governor, draw up a program. And by the way, draw up a financing scheme for the program. And first sign of trouble, Shumlin appointed as the chair of the board to do the design work a woman whose last previous job was president of the Blue Cross Blue Shield Foundation, and who had played a major role in pushing Romney Care in Massachusetts. We were worried. Well, the one thing that was clear in that legislation was a lot of detail about setting up the insurance exchanges under the ACA. There were 42,000 uninsured before the ACA. The estimate was that 28,000 would acquire coverage. And others would also use the insurance exchanges because Medicaid was going to go through this exchange. And the initial cost was $170 million to set up this exchange. with another $92 million expected over the ensuing 3 years. So to cover 28,000 people, they spent $218 million. Now, if you do that out, anyone? It's almost $10,000 per person just for the administrative apparatus to administer the coverage. Big mistake. Now, when Shumlin finally came out with his plan in December, he said we're going to have the insurance administered by a private insurer. He said we're going to continue to have Medicare, TRICARE, and private employer coverage continue. Partly because we can't get around ERISA easily, but partly because we're not going to apply for the waivers from Medicare and TRICARE. And he said we're going to pay hospitals, not global budgets, because we can't, because we've still got multiple payers in the field. And we're not going to pay them just for their operating, we're going to let them get the money for their new buildings by saving money on their patients. And finally, he put forward a regressive financing scheme. He said 11% of income will be the tax to pay for this health insurance program, but over $200,000 a year in income, no more tax. So there was an uproar after the plan was introduced because he said we're going to raise $2.3 billion in new tax money. Now what wasn't said is we're going to save $2.2 billion in premiums and out-of-pocket costs. So the whole plan would have cost about $100 million in extra money in Vermont, largely because they put it in the hands of private insurer, which they said was going to keep overhead right where it was instead of cutting it, and because they weren't going to get any savings from hospital budgeting or from doctors' simplification of their administrative costs. Not only that, but they said we're not going to bargain over drug prices, so we're not going to get any savings there. Even so, $100 million would have been offset by savings on federal taxes from Vermonters because all of the money they would have spent under this program would have been tax deductible under the federal government, whereas a lot of it wasn't tax deductible under the existing system. So on net, even with this faulty plan, Vermonters would have, by Shumlin's estimate, saved something like $100 million a year. But that was never advertised. It makes you wonder how much the governor really wanted. Well, as I said, there were design flaws that had serious implications. And when the governor announced his plan, he announced very loudly the new taxes, but didn't announce very loudly the savings. In fact, buried in the fine print of the report is that most of the 340,000 Vermont families that earned less than $150,000 annually would have gained, but most of the 24,000 families above that income would have lost. Employers' costs would have risen a little bit. What went wrong? Well, in Vermont they used single payer label, but the plan was vague and ill-defined at the outset. Key policy advisors and designers, once they called them in, were not single payer supporters, but in fact were people who had no love for single payer. They yielded a flawed design that had few savings and precluded comprehensive affordable care. So instead of saying to people no co-payments, no deductibles, they had to have a plan that did have some co-payments and some deductibles, though better than most. They couldn't cover long-term care, which we ought to be able to do for what we're now paying. And finally, during the most recent gubernatorial campaign, and one has no way of knowing how big an influence this was, there was an outpouring of corporate money into Vermont to tar the single-payer, so-called single-payer reform as a reform that was bad for Vermont and that almost defeated Governor Shumlin in his run for re-election. Came very close. Well, that's my summary of what went wrong in Vermont. We can do better elsewhere, but we need to learn lessons for how we do better. Now, the main thing we have going for us is that most people want what we want. So if you ask people, this is a ABC News, USA Today, Kaiser Foundation survey, would you prefer the current health insurance system or universal coverage program like Medicare government-run, financed by taxpayers. 56% in this survey said it. Varies between 52 and 65% in various surveys. If you ask, do you prefer socialized medicine, only about 51%, 52% say they favor the S word. By the way, 18% of Republicans in a survey said they would favor socialized medicine. 18% of Republicans with that label. If you ask doctors in Massachusetts, where we've had Obamacare now for 9 years, single payer is the most popular single reform. 22% favor public option, which I think in many respects is confused with single payer. 15% would go back to the pre-Obamacare kind of reform. 19% say what's in Massachusetts is working well. Many who oppose Obamacare do so because it didn't go far enough. So we're used to hearing this line that Obamacare is on. And that's our problem, is that we're paying for an enormous industry that uses its financial might to resist reform. Now, if you ask, on the other hand, Canadians, would you prefer the U.S. system? And this is a question that's been asked repeatedly. I have the earliest version of it I could find. In the U.S. system, government pays most of the cost of care for the elderly, poor, and disabled. Most others either have health insurance paid by their employer or have to buy it. Some have no insurance. Under the U.S. system, people can choose their own doctors and hospitals. That's sort of an optimistic view of our healthcare system. On balance, would you prefer the U.S. system or the system we have here in Canada? And they know our system. They read our magazines. They watch our TV. And 3% of Canadians, pretty consistent finding through the years, are prepared to go back to that kind of system, which one of my Canadian colleagues has informed me is roughly their illiteracy rate. Well, the good news is that we know that the healthcare system can be fixed and that we have the resources to do the job. We spend by far enough money to give everybody in this country superb care. But we can't waste it on the absurd structure we've evolved around our healthcare system. And the unfortunate part is that those folks who are profiting from the irrationality of our system have amassed great political power. But I'm still a believer in our country, and I'm old enough to remember that major changes do happen in our nation. They happen sometimes suddenly and unexpectedly. I remember when the Supreme Court Justice who'd been appointed by a Republican governor of Massachusetts led her court in ruling that gay marriage was legal. It was, what, 10 years ago now? And people thought that that was a wildly inappropriate suit to have brought that would set the course of gay rights back a decade or more, because it was impossible to proceed on such a radical demand. And now we know that our country can proceed quickly on that demand. So we make sudden and unexpected changes, and we can make this change suddenly and unexpectedly as well. I thank you for your time and attention.
Thank you, Dr. Himmelstein. I hope that his exhortations will cause all of you to go forth and multiply and find other people to whom you can spread the word. We're, again, as I said, offering the opportunity. We have sign-up sheets in the back. We'd love to have everybody on a mailing list from either Single Payer New York or for Physicians for National Health Program, so that we can keep you informed. And I think I'd like to give the people in the audience an opportunity to ask questions. We have I think we have a portable microphone, or you can just stand up and talk. I think we're small enough here if you have questions that you could just ask them from your seats.
You know, I really think this talk belongs on the front line. How could that happen?
You tell me. How do we get on front line? I mean, we've at various times had some useful media exposure. I was on Bill Moyer's show, and back 2 decades ago, Walter Cronkite actually did a special comparing U.S. and Canadian healthcare. But I think what we need, frankly, is the media to hear from people that they want to hear, not just this talk, but much more coverage of the possibility of real reform. I had the opportunity to speak for 6-7 minutes this afternoon on WAMC, and that came because people locally called WAMC and said, we want this issue on your radio station. I think that's what gets it on. I surely haven't said anything controversial. I think, David, we're right in front of you.
So, in New York State, do you think it's possible to have a single-payer system set up? And if so, how can we go about doing it in a way that we won't have the same mistakes as Vermont?
Well, I think New York State has considerable momentum already. Richard Gottfried, who's the chair of the Assembly Health Committee, has a quite presentable single-payer bill. This is not a vague idea, but a fairly carefully thought-out bill, which already has a majority support in the House. Now, any of you who are familiar with New York State politics know that it's very easy to support something in the House if you're sure the Senate is not going to support it. So our task is to influence the Senate at this point to move as well. But frankly, I think that New York has real possibilities, if for no other reason than we're such an enormously high-cost state to begin with, that we've got a huge amount of fat to cut. And our Medicaid program is by far the most expensive in the nation. So in terms of public funding, we're way above average already. We're already spending so much in public dollars in this state that the transition to single payer would actually financially be much easier than even in a state like Vermont. So I think someone mentioned Lobby Day coming up in May for the New York single payer bill.
May 5th.
May 5th. Yeah.
Hi. You talked a little bit in the beginning about how electronic health records was initially the reason why you had this issue, the Kaser health issue, the patient, 59-year-old. I'm wondering how potentially electronic health records might be assistive.
Yeah.
This.
Well, so I'm both a proponent and a critic of electronic health records. I spent actually 20 years as the director of clinical computing at a hospital. I resigned in disgust at what was actually happening with clinical computing. So it's an enormously valuable tool, and yet has been turned into essentially a billing record that clinicians are slave to. And hospitals and practices are forced to buy a computer system, electronic health record, that is based on the billable unit, the patient as a commodity, and where clinical needs come last. And I say that with great regret. I think it could be a tremendous boon to patient care, and yet at this point there's an enormous amount of documentation in the medical record which is completely unreliable, another part which is completely useless. Instead of having a brief note that you can read through that informs you about the patient, you've got a voluminous note that tells you almost nothing about them, and a huge amount of time of the clinician taken up in dealing with what is essentially an administrative tool. Just to give you some sense, the pioneers of the electronic medical record are colleagues Warner Slack and Howard Blake at Beth Israel Hospital in Boston. And they designed a model electronic health record. The hospital never would entrust them with doing its billing. They started building this system in 1971. And by 1979, it ran virtually the entire clinical operations of the hospital. The way they programmed it, by the way, was interesting. They never hired programmers. They hired music majors. And the first thing they had them do when they went to program, for instance, the admitting department, they would have someone go and work in the admitting department for 4 months. And then they would teach them how to program, and they would tell them there can be no instruction manual. There can be no training. The program has to be so obvious as to how to use it that the day you put it up, the people in the department you worked in will know how to use it. And that's how they computerized that hospital. And by the late 70s, early 80s, they had computerized virtually the entire hospital. But they had half of the computer budget for the hospital. At midnight every night, they turned over a computer tape with all of the clinical activity of the hospital to the billing department, which had the other half of the hospital computer budget. That system was eventually taken down because the administration felt it was insufficiently friendly to the needs of bending clinical practice to the administrative necessities of how you charge. It didn't say, as an outpatient, you can't charge for diabetes without a complication, which is what you need to do in this day and age. So it's a long-winded way of saying computerized medical records are a tremendous capability, and it's being squandered at this point. We've done a number of studies of what the actual implications of it are. So it's supposed to decrease the repeat testing because you'll be able to get the tests that were previously done better, but in fact it's increased the amount of x-ray testing and other high-tech testing because largely the system is designed to do that. Makes it very easy to put it in order. So there are a number of other quality measures that it looks like haven't improved, though one would expect they should. I would say there are 4 systems, 4 computerized medical record systems that have been shown to work. One is the Beth Israel system, which no longer exists. Second is the Regenstrief Institute in Indianapolis, which was designed by 2 people there on the ground. Third is the LDS Hospital in Salt Lake City, which again was designed by clinicians on the ground. And the third is the VA system. The fourth row is the VA system. Yeah.
Anyone else with a...
Here we go. Both up front and...
I just had a quick comment for this. I'm a primary care doctor working in private practice, and just last week our office manager came out and told me that...
Now, the primary care doctors get fined for each billing seminar they miss. Now, the primary care doctors get fined for each billing seminar they miss. So Medicare ought to be able to outcompete the private plans, but it can't. It can't because the private plans are willing to cheat. And my worry is that if you're willing to cheat, if you're willing to try and selectively attract healthy patients and selectively exclude unhealthy, expensive patients, that what happens is Medicare ends up with the money losers and the private option ends up with the money winners. So that, in fact, the public option becomes, in effect, a subsidy to the private plans. Now, Medicare has in place all kinds of regulations meant to stop that kind of risk selection. But it doesn't work. It doesn't work for a variety of reasons. One recently came out in New England Journal that plans, for instance, have used their formulary tiering. I don't know if folks are familiar with formulary tiers. So there's, like, the cheapest drugs might be a $5 copayment. And then there's the next group might be a $10 copayment. And then a $25 copayment. And then the most expensive, you might have to pay 20% of the total cost of the drug. And originally, these drug copay tiers were like, well, the lowest cost option of an equivalent drug will be in the low cost tier. So if there's ampicillin versus a brand name ampicillin, the ampicillin generic is in the low cost tier and the brand name is in the high cost tier. Okay, but that's not what they're doing. What they're doing is they're saying every drug for AIDS is in the high cost tier. Generic, brand name, anything. And what that means is if you've got AIDS, you're paying extremely high costs for your drugs. And what that means is we're trying to scare away AIDS patients from this plan. Now that's not illegal because they're not saying you can't join if you have AIDS. In Massachusetts, when this survey was done, my health insurer, Harvard Pilgrim, has not a single drug in its low-cost tier for AIDS, for psychosis, for seizure, for asthma, or for multiple sclerosis, or for rheumatoid arthritis. Now, if you have not a single low-cost drug for any of those illnesses, the message you're giving is, we don't want those patients, and it's very effectively delivered. So there's all kinds of nefarious ways of competing, and I think the playing field can't be leveled. You know, at first they used to do kind of the grossest things, like they put their sign-up office on the second floor of a walk-up building, but then, okay, that got outlawed. But now they've got some other ways. Another way is to say, yeah, you've got cystic fibrosis, and there's a pediatric cystic fibrosis specialist clinic in this community, but we're not contracting with them. So if you've got CF, you don't want to be in our plan, right? So I worry about that as a strategy, that it may end up being, in effect, a subsidy rather than a competition.
There may be other great questions. I just wanted to say that we have been showing the healthcare movie, which outlines the development of American and Canadian healthcare over the last 70 years, and illustrates many of the points that Doctor has talked about. And I called the film producers up, and we got a low-cost price of $10 per film. And I sold 5 out at the East Greenbush Library for people to show to their friends and their neighbors in their home. You can't show it in public because that's a special license. But I have some for sale here. And the theory of movements is that they're slowly developing the grassroots, and there's a whole methodology on this if you think about it. And we'd like to offer these to you for $10 a piece for your use. Thank you.
Thank you.
I'm sure Dr. Himmelstein will have a little time to talk to people. No, one more question.
One last question.
Well, just a brief statement. I feel quite fortunate. Late last spring, I say around June, I guess, I was diagnosed with stage 4 renal cancer. And I was cured at New York Oncology. Excellent treatment, and the money I have to pay is quite reasonable.
Glad to hear it. I mean, we can do amazing things in medicine today, and the crime is when we don't do it. And we ought to be doing them for everybody, because we can do them for everybody in this country. So glad to hear your stories.
Thank you, Dr. Himmelstein. Thank you all for attending.